Good morning, good afternoon, good evening, everyone. You're welcome to today's episode of Public Health in Real Life, a channel where we highlight key global health issues, celebrate heroes from the field, and inspire the next generation of global public health leaders. On today's episode, we want to highlight World TB Day, which is celebrated every 24th of March. And the aim of World TB Day is to raise awareness on tuberculosis and to then increase efforts to end the global epidemic. We are excited that today's host and our guest is Dr. Obioma Chijioke-Akaniro. Dr. Obioma Chijioke-Akaniro is a physician and a public health practitioner who is also the M&A manager of the Global Fund's Program Management Unit in the National Tuberculosis Program in Nigeria. She serves as the secretary of the National TB Operational Research Task Team in Nigeria and has been involved in several public health research both in and outside of the country. Dr. Akaniro is a member of the country's advisory group on the Light Consortium, a partnership that spans across 5 countries, including Kenya, Malawi, Uganda, Nigeria, and UK. She's a recipient of several national and global awards and a fellow of the West African Institute of Public Health, a designation that she has gained due to her achievements in the public health sector and as a global data fellow. She's worked several years in forming program decision using data trends. She sits on several foundation boards and she continues to dedicate her time and expertise to improving health outcomes for underserved communities. You're welcome to today's episode, Dr. Akaniro.
Thank you so much, Dr. Mimunat.
We'll get straight to the business of the day, but before I do that, I want to highlight some WHO stats regarding tuberculosis. It says that 74 million lives have been saved since 2000, since the year 2000 by global efforts. Yet 10.6 million people fell ill with TB in 2021, and 1.6 million of those people died of TB in that same year, 2021. So with all these stats, let's just start from the basics. What is the significance then of World TB Day?
Okay, thank you so much for that question. For World TB Day, it commemorates the day that Dr. Robert Koch announced the discovery of the causative agent for tuberculosis, which is Mycobacterium tuberculosis, a bacterium actually. And part of that, the World TB Day is now celebrated every year at 24th March, which actually commemorates that day. But the reason for this celebration is to bring to bear the efforts that is being put towards TB program or TB eradication or TB control, depending on where the country is. So we try to put up some awareness and also to harness resources or bring to bear such that people can commit to efforts or put in efforts in the control of TB. If you look over the years, you will see that one thing is certain. At the celebration of World TB Day, you see a lot of awareness. A whole lot of people get to hear more about TB. So push that and ensuring that more people get to know about TB is one key reason for the World TB Day celebration. And through that, you actually showcase the gap by showcasing what the achievement is, where we need to be, and the gap. And now by that, see a way of fostering effort so that people can all join their hands for us to eliminate this disease, which is treatable. And if found, the person can be treated back to your normal activities just as quick as possible.
Thank you for that response, Dr. Akaniro. The theme for this year's World TB Day says, yes, we can end TB. And we listed, some of the stats of the progress till date. So in your opinion, what are some of those strategies that have led to at least the gains that have been seen? And what are the challenges that have also contributed to us not getting to where we need to be to end TB? Because you said it's preventable and curable.
Okay, so for the TB, that there are lots of gains that have been made in the platform of the TB program. Of course, we have some challenges also. But the most important thing is that we're able to, in showcasing our gain, we're able to also showcase exactly what we need to do further. For the TB program, for the World TB Day theme for this year is actually very significant because they say, yes, we can end TB. And there's also a slogan that says, get involved. So it's calling on people to get involved. Yes, we can end TB because if you look into the space, you see we have what it takes. We have the human resources. We also have the equipment. We have some new innovation of equipment that can help us to do this. And based on that, of course, we can eliminate TB. But um, even though we have all these, we still lack the resources to make it very available, such that people can easily get access to it and be detected or be diagnosed if they have TB. And for us in TB program, we keep saying that Nigeria has shown an example that yes, we can end TB because we come from a point where the country was barely diagnosing 25% of its burden each year. So we had plateaued on 25%. In fact, we had sometimes where we were diagnosing like 10%, 15%, and we got to 24%, and we plateaued there for a whole long time, diagnosing just up 100,000 cases each year. And some things happened, and just that, well, there was this kind of awakening to innovation and awakening to think outside the box and to put some things like a menu of innovation together. And gradually, we and our partners all together, we started seeing that yes, this is possible because a whole lot of cases were able to diagnose more cases than before. And gradually, we saw ourselves move from 24% to 27% to 30% to 44%. And in 2022, we got to 60%. We diagnosed 60% of our estimated burden in 2022. And we are pushing further. And we're like, okay, that means we can do 75%. And that means that we'll wake up one day and we've done 100%. So yes, it's possible. Yes, we can end TB if you get involved. And that's why we are calling people to get involved. Those who need to give different kind of resources, kind of maybe financial resources, the individuals who can help us to spread the message, everyone together, because the more people know about this, the more we have people who experience these symptoms also come out to assess the necessary diagnostic tests.
Thank you, Dr. Akaniro. It's actually great to hear the progress in terms of diagnosis from 10, 15, plateauing at 25, and now actually getting to the north of 70%. So I want to harp in on the portion of what you said, because the key to effective treatment is diagnosing in the first place. And it seems like that's where the program stalled for a while. We all know how TB is spread and how it can go undiagnosed because of latent TB and so many factors, where there are many people in diaspora, for instance, who didn't even know they had latent TB until they had to do, some medical examination of some sort. So the question then is, how do we close that diagnosis to treatment gap, and how do we expand, the efforts to really ensure that there's adequate and effective diagnosis of TB?
Okay, so the TB world has actually made some advancement, and especially in the diagnosis of TB. Right now, we have some machines which can actually diagnose less than 2 hours, like we call it the molecular test, using genetic detection for the mycobacterium tuberculosis. So with that, having that machine, bringing it on board, actually a game changer for the TB program, because with the newer technology, no matter how trace the mycobacterium is in a sample, you can actually detect that. So, but the challenge is having to have large coverage with these machines. Of course, they are not also very cheap equipment to procure and to put in place. So practically in Nigeria, we have done a lot in terms of ensuring that we have a lot of this equipment placed in different local governments, such that the patients, we can be able to ensure that the specimen from the patients are moved to this site. So what we do to avoid our increasing out-of-pocket costs for the patients is that we try to, we instituted a sample movement mechanism such that from where the sample of the patient is taken, it can be moved to the nearest molecular diagnostic site. And by that, it helps us to cushion the effect that we don't have it placed in all the local governments. We're moving to have it placed in all the local governments. In fact, in 2023, the first, in fact, one of the first things we started putting in place in this 2023 is that we've mapped all the local governments where we don't have one molecular test. So we are also working on ensuring that we place at least one in every local government. And further, microplan the specimen transport mechanism such that even within the local government, it's really easier from different wards, different communities to move the patient specimen to, or the presumptive specimen to these places. And the good thing for it is that this test can be done and collected in a day, and patient placed on treatment immediately. The only thing that can distance the diagnosis and placement on treatment, like give a gap in it, is when you're not able to get to the diagnostic sites as quick as possible and get the results back. And when you start having this gap, that's when you start having patients that are lost to follow-up, pre-enrollment lost to follow-up. And at that particular time, you've missed an opportunity to place the patient on treatment. So what we do in the country to cover up with the diagnostic and treatment gap is to ensure that this specimen referral system is up and doing, and also to ensure that we push further the molecular diagnostic test. In fact, we call it WHO recommended molecular diagnostic test to every local government. And in the future, we would be able to get it beyond the local government and further increase access to them.
It's really great to see the gains made in that, like you said, the diagnosis to treatment gap. So now we'll speak about the treatment. Historically, there have been issues with access to TB treatments because of the nature of the medication, because of the need to have the medication for most times taken under supervision, and because of even the availability of those medications. So could you highlight some of the strategies that have been deployed to increase access to treatment, and what are some of those gains that have been recorded, at least from Nigeria and some of the countries you've worked in?
So graciously, the Global Fund has been funding the Nigerian TB program together with the government of Nigeria, and also the USAID, that's the US government. Particularly, we are able to say that we have these medicines and consumables in country because the Global Fund has funded it over these years. So for every patient we diagnose, we're able to place on treatment. And to just tell you that this treatment, both diagnosis and treatment, is free, are free in country. And the fact that they are free doesn't mean that it's cheap. It's actually expensive. To treat a drug-susceptible TB patient will cost you at least $250. And when it becomes resistant, it will cost close to $4,000. But what we have done in the country with this is to ensure that we expand DOTS facilities. DOTS facilities are the places where treatments are being monitored. Once the patient is placed on treatment, you have routine monitoring, staggered for you at particular time, such that at that monitoring, the DOTS focal person is also looking at you if you're doing well with the drugs, and the test will showcase if you should continue on that drug, if there's any other thing that needs to be done. So what our endeavor is to ensure that every facility in the country provides DOTS services, every facility, such that once a presumptive or a Nigerian who feels that he's experiencing these symptoms move into a facility, they will easily tell you, okay, there's a DOTS somewhere in this facility where you can access this diagnosis or treatment. So far, in just a few years, 2018, we had about 9,600 of our facilities offering DOTS. But between then and now, just a couple of years, we've been able to move further to about 20,148 facilities offering DOTS, meaning that about 50% of the facilities in the country are offering DOTS services. But we didn't stop there. We went further to do what we call referral system. For some facilities, before you establish DOTS in a facility, there are some standard things that you should see in that facilities. So we have a WHO checklist that help us. Together with WHO in country, we kind of do that checklist and look at those facilities and see if the facility has a minimum standard like the HR, the space, and because we need to build the capacity of the HR to be able to handle these patients. And also, by the time we establish, we now further continue what we call monitoring and supervision to ensure on-the-job supervision, just to train you, on the job training or capacity building, apart from the capacity building we have done. So we ensure that the patients that come in are well handled. But if that facility does not have that minimum standard, we then make it a referral facility. It means that patients who come here and they are presumed to have TB or have developed TB are now referred to a hub facility. It means that the referral facilities are now called the spoke. They are a hub facility. And in the hub facility is where you have the DOTS facility to assess treatment. So over the years, we have further increased. If you add our referral facility to our DOTS facility, we have more than 70% coverage of health facilities in the country. So our work is to ensure universal health coverage, to bring this as much as possible to the doorstep of the patients. But we didn't stop there. We further went into community, where we are partnering with community-based organizations. And what they do for us, we do house-to-house case search, active case finding. When you identify a case of TB, we trace down to your family. And we do this using TB survivors, who we call community TB workers or volunteers. They help us because knowing exactly how they went through this, they help us to trace these families without raising awareness or kind of bringing up stigma around them. So by that, we now go to the facility, to homes of these TB patients to look at their, screen their house contacts. By screening their house contacts, what you do is to identify those who within that family have already developed TB. And those who have not developed TB, once you screen, you place them on preventive therapy. For those who have developed TB, those you see signs showing that they may have developed, you now link them up. The community-based organizations also help us to move this specimen to the places for diagnosis. By that, you see that all we're trying to do is to ensure as much as possible that we reduce out of patient costs for these patients, and also to get as much as possible within their doorstep.
It's really great that you highlight the role of the health ecosystem in successful management of TB and really any other public health issue. So speaking about health systems, we all know the role COVID pandemic played in just the gains that had been made in several key issues. So how did the COVID pandemic impact the gains or the progress made with TB, and what are TB experts like you doing to mitigate some of that effect?
Okay, so we just in 2018 we just returned from the UN high-level meeting on TB, and where we had a particular goal for each country, like what each country should work towards in terms of their burden. So globally, we had put up that between that 2018 and 2022, we should have done remarkably well in controlling these diseases globally. But you can imagine by 2019, globally, we had identified 7.5 million TB cases out of the estimated 10 million people who developed TB that year, which was good. In fact, the global TB reports that year were like, wow, that's a good start. And imagine after that, the next year, 2020, was the pandemic. And by the end of the pandemic, globally had decreased by 18%. So from 7.5, we had gone down to about 6 million cases, about 6.2 million cases identified, because a whole lot of countries, all the implementations and interventions and the gains made was um, kind of lagged, because a whole lot of attention had moved, and a lot of patients also weren't even accessing or going into the facilities to access care. So between then, 2020 and 2021, we globally now about 6.7 million had just gone up by about 8%, trying to come back to where we were in 2019. So it shows you from the global picture what happened in the countries. But I just want to tell you that in Nigeria, we didn't observe this curve. In Nigeria, we're one of the very few countries, I think about 10 countries, that maintained a gain in 2020. At the end of the pandemic, in fact, we increased by 15%. And it was a good lesson for us, because it showed that it kind of gave us like buttress the ideas that we have that we really can do it in country. So by the time we moved from the treatment coverage where we had from 24%, as I told you, to 27 to 28 to 30 and 44, it was kind of a trend of, yes, we can do it. Yes, we can do it. Even if during the pandemic, if we could do this, it means that we can do better. So what we did as a country was just quick response, and I think that is also what is being done now globally, because we already had the community system on ground. We found out that the community system could help us. So immediately the first case was announced in Nigeria, we quickly rolled out an SOP for the community healthcare workers, for those working in facilities, like triaging between TB and COVID. We rolled out that SOP, active case search in the community, observing non-pharmaceutical measures. Those things we rolled out, and we started pushing it to the people working on the ground, and we found out that it helped. And also in the private sector, we had launched the private sector, the PPM strategy. We found out that even the PPM, we didn't have cases decrease. In fact, it was more like PPM was like a shock absorber for us as a country. So we learned the lesson that having a resilient and sustainable community system helps. So in whatever we are doing as a country now, we'll put in the community aspect, community-led monitoring. How do we ensure that they sit at the table? They start with us from the planning. Whatever we want to do, they are at the table with us. They start with the planning. You build their capacity as they move from with us, from the planning, the development, exactly how the whole implementation would go. And by that, you see them being able to do this. So that capacity building and getting them integrated in what you want to do will help to build a resilient system. So when it seems as if some things are happening, those at the community who are closer to the patients, work continues. And it is their work to ensure that they link these patients, or they link the presumptive, they move the specimen for diagnosis, and the drugs are also brought to the patient. So those little mechanisms that we had put in place were the things that gave us the lessons learned to make us know that community, if you can raise a resilient community system, you'll be able to go through whatever storm it is.
Yeah, it's definitely great you mentioned the term resilient health systems, because I know that was a recurring theme during at the height of the pandemic. You've mentioned various stakeholders involved in improving the effort, or increasing the efforts to end TB, to mitigate the effects. You are a public health scientist yourself. So what role do you think research plays in ending TB? Like, what are still some of those areas to prioritize in terms of research to achieve the goal?
So research has taken us a long way. And when I say that, I mean that even in the programming country, the life we live every day, the things we do, the implementations, the interventions, are all research for us. So at the end of the day, we're looking through it, we are identifying the things of what's best for us, and we are upscaling it. Some of the things, some implementations, we just try it out in a particular community or in a state or a few states. We see how well it has worked. Then we now go on and say, oh, with more research or more resources, we can upscale. But the thing is that you only upscale to as much as you have the resources for, because
Yeah.
all these things require resources. But let's go through the diagnosis and treatment for TB. You see that there's a lot that has happened in research. We have gone from the point where we use a microscopy, doing AFB microscopy to find the germs, to where we now use the genetic material. It means that the slightest presence of that, you'll be able to pick it and put the patient on treatment. And with that, we've also gone forward to the point where that when you diagnose, you don't just diagnose that the person is TB positive. You also can tell if the person is resistant, so that you shorten the gap on placing on appropriate treatment. So it plays key role, and that's why research is one of our three pillars. The three pillars of ending TB, NTB strategy. The three pillars: integrated patient-centeredness in your approach, ensuring bold policies and supportive environment for people to work in, and innovation and research. So you can see that these three things, if you put it together, definitely you do well. And that's what we try as much as possible to do as a country. In the last few months, all we did was to look at our gaps. We did what was called people-centered framework. We have very wonderful partners in Nigeria, which if I mention all the list is a lot, but I know if you Google, you would see a whole lot of them. And I don't want to mention any and drop out any, because every of them is important in these gains that we have made. And in the people-centered framework we did, all we looked at the framework, the continuum of care of a TB patient from the beginning, where this person is in the community and should just be identified by mere screening, down to treatments completed or treatment the disease being cured. We look at all those, and what exactly do we need? What do we have? What are the gaps? We looked at the gaps and we said, okay, with these gaps, what do we have? What can we do better? What do we have? What are the things that have worked? So it was more like kind of a SWOT analysis and kind of an evaluation and all those. And by that, we're also able to identify exactly what we should scale up as a country. So most of what we're going to do in 2023, we are just kind of setting the platform for some of the things we'll take off in 2024, especially in terms of diagnosing children, which is one of the most difficult things to do, because they can't really tell you how Tom is, they can't produce the specimen when they are a lot younger. So you really need high index of suspicion to do that. And we have decided, if you look at globally, 7% of children, the percentage of children that are diagnosed, you see it's the same way cutting across in a whole lot of countries. But we've also made up our mind in the country that we really need to change our narrative. So part of what we are doing, we've looked at a couple of research, we've done a couple of research, and that is what we're going to write on to ensure that we also close this gap. So research is an important part of this program.
Yeah, it's great to see that, in terms of like research and innovation, how much progress has been made. Like you said, diagnosis, treatment. I think one of the, like you mentioned, and thank you for, reminding us of the three pillars of ending TB strategy. So I'll touch on that second pillar you mentioned about policy. It seems like Nigeria has made significant gains with all three pillars. So for countries that are still struggling with TB or with like high TB burdens, what advice would you have for policymakers, or recommendations would you have for them to move the needle in getting to where they need to be with ending TB?
Okay, the advice I will have for them is make good policies, and I would say make evidence-based policies, evidence-informed policies. Let it come from evidence. You can make beautiful policies and they won't move. you won't gain grounds with it. But when it fits from evidence, you would see that it gives you a better leverage to, bring to bear whatever it is that you need to address at that particular time. And not just in policy making, but the environment, the
Mm.
supporting environment for it. Because we have some of our partners that come with very beautiful ideas, say, oh, why don't we do this? And it's within us to say, yes, what do you need? And in what you need, you go ahead, kind of to till the ground, to water the ground and make it easy for the person to implement or to try out that. And because you see, one of the big ideas we have in the country is one of our partners that had been able to use the motorized tricycle, which in Nigeria we called keke. So we have wellness on wheel on keke, and you can imagine wellness on wheel on keke, and inside the keke you have the portable digital X-ray with artificial intelligence in it. You have molecular tests that like either the tuner's machine, that's or the TB lamp, which they would take to hard to reach areas. When car stops, the bicycle continues, the motorcycle continues. So when the car stops, this tricycle will continue into the villages. And inside that keke or inside that motorized tricycle, you have both the diagnostics, everything you need in the community to attend. So it's an idea, but it's for us to make the ground easy for them. So apart from the policy, ensure that the policy is evidence-based, but still go ahead and make supporting environment. And if you make supporting environment, it's not by just saying we need to make supporting environment, it's by really making supporting environment. You can only make it by really going into the field and make it for these partners or the people who really need to ride on those policies to ensure results.
Yeah, you're absolutely correct in terms of that policy to implementation gap and how it's very important to ensure an enabling environment. And I like your anecdote of the keke, and how you can combine technologies and make sure that it's suited to different contexts.
Mm-hmm.
Imagine having the most advanced can, then it can't reach the most remote setting. You have to think outside
Mm-hmm.
the box. So it's really great to
Yeah.
hear that. We've really talked about a lot with the gains, the challenges, successes, advice, recommendations, the pillars. So I'd ask you, what do you see the future of ending TB efforts as?
Oh, I think I have faith and a big dream for what will happen in the nearest future. I am looking at point of care tests.
Mm.
The earliest tests we have now is just above an hour. Can we have something bedside where just by the bed you can have a test, diagnose and place the patient on treatment? Because with that, you will see that the gap between diagnosis and treatment will close. So the pushing for that point of care test is one important thing I would like to see in the nearest future. And I know we have the shorter regimen that is coming up in TV, but can we have the shorter regimen, like a 1 month shorter regimen in TV? Presently, we have gone from 6 months to 4 months. Even the DRTB have gone from a way over 24 months to 18 months down to 9 months. There's a 6 months now that is coming on board, which a lot of countries are now adopting. But we have a 1 month treatment for TB. The adherence of this treatment, what it takes to take drugs every day for 6 months. Imagine if we can make it for 1 month, that would be a whole lot. So those are the things I see for the TB program in the shortest time. And I know that research and innovation is going on. We'll get to that point.
Yeah. Prior to this, we're talking about many years ago when we met at the Global Health Effectiveness Program and, all began our respective journeys into global health, and where we had the opportunity and privilege to meet the late Dr. Paul Farmer. And we all know of the work he has done in improving access to medications, drugs, and treatment for people with tuberculosis, and just like they call it, the preferential options for the poor. So could you just share the story, anecdotes, and all of your journey into global health and how you came into being the TB expert and supporting the work that you do?
Dr. Maimunat, when we met at Harvard, I wasn't in public health core yet. So most of the things that Dr. Paul Farmer was telling us, Dr. Joya was telling us, they were just inspiring things. And I didn't know I was going to find myself in the TV space itself. But just a few years down the line, I find myself in TV space. And it was more like as if you rehearsed before you came into this place. Those inspiring words, so far they went, to ensure the establishment of drug-resistant TB in the world. Those are the things that I know a whole lot of us in the public health field have in mind. And I see what a whole lot of us are doing. I'm like, wow, that's exciting, that's amazing. And I can't thank them enough for what they did for us. But then let me just tell you that I went to Rwanda for an international review with WHO. And along the way, I saw partners in health. You can imagine seeing partners in health along the way. I felt I was home, like I almost jumped, like, oh, please, I need to go in there. And when I moved in there, I saw his picture. And I kept telling everybody, yeah, we're students, the work. And you will hear a whole lot of stories from the local of what he meant to them. So I would just advise every public health physician, the space where you occupy is for humanity. You can do more. It's beyond what you're paid. It's beyond what you take home. Nobody can pay you exactly for what you do. Drive is a drive. So we will just keep doing what we are doing and ensuring that we see the face of humans in our public health endeavors. And I also encourage a lot of young people I see coming. That is the first thing I tell them. I say, this is an opportunity you have to help people. So it's more like charity work. Do it. Be satisfied in doing it. The pay is not the focus, because you cannot be paid for it if you do it with the whole heart, because a lot, and you have extra miles to go to ensure that these people, they recover, they stand on their feet, and they go back to their families and loved ones in health. Thank you.
No, that is very inspiring, and thank you for reminding me of some of those, sessions and what we heard. Yes, it is definitely life changing.
Yeah.
Lastly, before we go, you've shared a lot of advice. What would you say to everyone watching this and anyone who would watch this, regardless of their role or their level of expertise in TB, and the role that we all play to ending TB? Yes, we can end TB.
Okay, I just want to say, TB is not well funded. The resources are not so much to be able to do everything that we have in mind to do. But we are grateful for what we have, because we even have some to work on, with which we stretch as much as possible to see how much it can cover. But I would advise everyone, if you're hearing this, you're also a channel to convey. We need to create awareness. We need to ensure that a whole lot of people, we may not have such funding to do all the jingles and things we need to put on board and get a whole lot of people. If you go to a community and you ask a small child, they know HIV, but it's not like that for TB. For TB, just 24% did a KAP survey, and just 24% have knowledge of it. So you can see we're very far away. So we ask everyone to be on board with us. If you're a private organization, you can join us. We have the corporate social responsibility, which you can leverage on that platform. And wherever you are, we are open in the program to work with anybody. You just walk to the State Ministry of Health, Federal Ministry of Health, just ask for the TB desk. That's all. You are on board. We have IC materials. We can help you for community outreaches, just to get this message as far as possible. So we welcome people on board to join us in this, because the more we get this message out, the more people who feel the symptoms, even some people coughing out blood, actually some of them may not even know that it's TB, and some of them will say maybe it's poison, maybe it's this or that. But the more we get people to know about it, the more they access treatment and live a healthy life. Thank you.
Thank you so much, Dr. Akaniro, for sharing all of those resources. Lastly, you talked about your passion, the work you do, and I see the evidence of it. So, for any audience member watching you who wants to, reach out to you to learn more about your work or to just connect, what are your social media handles and how can they reach you?
Okay, so you will reach me on LinkedIn, Obioma Akaniro, just that, Obioma Akaniro on LinkedIn. So if you just write me a mail or you send me a request to connect, I've had some people connect, and we have like very fruitful discussions of what to do next. We also have some people who we mentor who are also in the field, doing one thing or the other, in the field of public health. So if you just go on LinkedIn, you see Obioma Akaniro, you can send me an invite and we continue from there. Thank you. Oh,
Thank you.
I'm sure you also reach public health in real life.
Yes,
You would always
yes.
get them directed to me. Yeah.
Yes, exactly. And yes, to our audience, please feel free to follow all of our social media handles. It's always our pleasure to bring speakers like Dr. Akaniro and several others on the field. So please follow us on social media, like and subscribe to our YouTube channels. Feel free to send comments on, topics, heroes and champions like Dr. Kaniro that are doing exceptional work on the field that we can, highlight. And as always, thank you for all you do in your respective fields. Be safe,
Thank,
and see you out there. Thank you very much.
thank you so much, Dr. Memuna. Bye. See you.